So today we're really going to focus on milk supply during the pandemic, and we could actually apply this to even non-pandemic times, but I believe that we have much more concern now because of what's happening with maternal-infant separation. I'm hoping that you got to join me previously for my earlier presentation. This is all going to be new and different stuff than the first presentation I gave for Medela in June. Today we're really going to focus on prenatal preparation, lactation risk assessment, and anticipatory guidance, and ensuring that critical window of opportunity for milk supply. So we know that the current practice paradigm is not working for mothers reaching their personal breastfeeding goals. In the U.S., we have tremendous health disparities surrounding human milk and breastfeeding, and we really are seeing that could potentially increase with the COVID pandemic. We also know that this is impacting the entire globe, and we have only 23 countries globally that have exclusive breastfeeding rates of over 60%. So clearly there are challenges with the provision of human milk and breastfeeding even prior to the pandemic. In the United States, we have approximately 4 million women who give birth, and over 80% of them choose to initiate breastfeeding. So we're talking about, in the U.S. alone, 3.2 million families who need evidence-based breastfeeding support and care. In this study, which is now a decade old from the U.S., you can see that upwards of 50% of women have concerns about milk supply. So that translates into 1.6 million annually. I believe those rates are actually even higher today in the year in 2020, as well as in the time of COVID. So I want to give you one piece of good news from the U.S. that I'm hoping may also have a global influence, and that is a congressional task force on research specific to pregnant and lactating women. This group has been meeting since 2017, and when I was asked to serve on this task force as the only PhD-prepared nurse, also as the only spokesperson really for lactation, I was concerned because at our initial meeting in 2017, milk supply was not even on the agenda, and I was worried that we could be talking about lactation-related research and not talking about milk supply. So my colleagues at the National Institutes of Health did a decade landscape view of publications related to therapies for pregnant and lactating women. And you can see here on this slide, there's almost 1,800 publications about preterm labor, and there's 1,400 about diabetes, but there's only 48, and this is in an entire decade, about low milk supply. And if you further look at original research, here you can see the amount of original research on low milk supply is less than 50%. So we're talking about, in a decade, about 20 research studies. Clearly, lactation-related research has not been a priority in the United States, and I would argue it's also not been a priority across the globe. This is important because if a mother has concerns about lactation and about milk supply, we have no therapeutic agents available to treat milk supply in the United States. So the Congressional Task Force did submit a report to our Congress, 388 pages long, with 15 key recommendations. And that report was developed and submitted between 2017 and 2018. One of the recommendations was to renew the task force, which did occur, and we have met between 2019 and 2020. And now, this year, implementation strategies will be submitted to Congress. Again, this is important because part of the strategy is to increase funding for lactation research, to increase and incentivize the ability to have therapies to treat lactation-related conditions. And hopefully, if we can have this occur in the U.S., it will also impact what happens globally. So with this background and the current COVID-19 pandemic, what is it that we as healthcare providers can do? When I initially started at Children's Hospital of Philadelphia after working on a National Institute of Health grant, I developed this 10-step model for human milk and breastfeeding in vulnerable infants. Now, I want to stress it was originally developed for mother and infant separation with babies requiring intensive care. But in this time of COVID-19 and the pandemic, this model still has great utility for all of our families, because what we know with COVID-19 is that not all families are having the opportunity to make informed decisions and participate in shared decision-making regarding human milk and breastfeeding, and not all families are receiving evidence-based information about the establishment and maintenance of milk supply. So does this model work? Well, at Children's Hospital of Philadelphia, we have had our labor and delivery unit open for over a decade. All of the babies who are born with us have complex congenital anomalies. None of them are, quote, normal. We have had a consistently high pumping initiation rate in our special delivery unit, upwards towards 100%, and we have consistently high human milk rates at discharge. And these are with critically ill children. We also have applied this model in Thailand, Japan, Botswana, around the world, and we do know that it does impact outcomes. So I think we can take this model and apply it greatly to the pandemic. And today we are going to just focus on the first two steps. When we think about informed decision making, we know that many women all across the world are not choosing breastfeeding because they have a lack of family support, a lack of awareness, a lack of education, a lack of exposure, or because of cultural considerations. We really do need to change the prenatal care paradigm. We should, during the prenatal period, be talking about human milk and breastfeeding at every single point of contact. And as I talked about in my prior webinar in June, focus on the science of human milk and how human milk protects their child in the time of COVID. We also need to give them appropriate prenatal guidance. We need to teach them not only the science of human milk, but the physiology of lactation. And the families need to understand that it is going to take time, effort, and commitment. So at Children's Hospital of Philadelphia, despite the fact that we have these very sick children, and we have these mothers with these high-risk pregnancies, we actually provide midwifery care in conjunction with the maternal fetal medicine care. And so we do what is called centering or group prenatal care. Now, we have to do a modified version because our families are not with us for their whole pregnancy. They transfer their care either between 16 and 20 weeks for in utero surgery if they have a baby with myelomeningocele, or at the start of their third trimester. And we do this group prenatal care, which has been associated with improved satisfaction and improved content. We do have the limit of about 6 to 7 mothers, and we have their partners and support people participate. All of the families have a lactation session in group prenatal care. And so this article was just released this week, and this is about our lactation outcomes among our families who were in group prenatal care. 100% of those families initiated pumping or breastfeeding, but remember, we have sick babies, so most of them are actually pumping to start with. And 87% were discharged from the intensive care units on human milk and breastfeeding. And I really, really think that this work is so impactful. And I myself am the one who participates and does the lactation sessions for our mama care, our group prenatal care. And I, as a PhD nurse, have always been passionate about high-risk pregnancy and children. And really, as you all know, having a child is a life-changing experience. But when you have a child that you know is going to be critically ill or may die, it is even a more life-changing experience. And by being able to work with our families, it has also changed our lives, and it gives meaning to the research and clinical care that we provide. So in addition to group prenatal care, our mothers also receive a personalized one-on-one lactation assessment and education. And in my session I did in June, I shared some of the outcomes of our one-on-one interventions. We really focus not only on the science of human milk, but we create a sense of urgency about starting pumping early and often for their child. We focus on exclusivity and dose and exposure. We also complete a maternal health history so that we can identify any potential lactation risk that could impact her ability to come to volume. We also want to understand the maternal lactation history and knowledge, as well as the information regarding their parents' breastfeeding experience. Because as we know, breastfeeding or lack of breastfeeding can be intergenerational. So we have to impact the entire family. We must identify potential risk factors that may influence milk supply prior to delivery. And so this article was just published earlier this year in the UK journal Infant, and this is an anticipatory risk assessment guidance. And you can really just identify factors that may delay lactogenesis to or coming to volume, and then also factors that could impact the development of a complete milk supply. Antenatal assessment is critical. There are so many risk factors that we can identify even prior to delivery. Obviously, we are going to know if it is a first-time mother. We are going to know her age, her weight status, and we know that weight is a negative impact. If she has any history of polycystic ovarian syndrome or any history of infertility, breast surgery, or insufficient glandular tissue. And again, this antenatal assessment is critical whether or not a mother has a healthy infant or an infant who is presumed going to be separated from her at birth. We still need to ensure that all of the families come to full milk volume. So we know that we have more older first-time mothers. So just being over age 30 can create a delay. If we add in obesity and a baby not feeding well, that risk of delay is even increased. In a baby-friendly hospital in Spain, they examined risk factors for non-exclusive breastfeeding at 3 months, and you can see here cesarean delivery is implicated, pacifier use, not college-educated, and not attending support group. Well, when I look at pacifier use, not college-educated, and not attending support groups, this, again, all goes back to appropriate prenatal anticipatory guidance and making sure that all families are making informed feeding choices and knowing the evidence and the science of lactation. If you look at 6 months, that primate parity comes out and the cesarean delivery is still there, pacifier use, and then return to work. And we know that return to work is a negative impact on milk supply all over the world. Now, I do want to talk about the cesarean delivery because since at least probably 5 to 10 years ago when we opened our special delivery unit, never really believed that it was the cesarean that was causing the delay in milk production. I really believed that it was the management of the dyad after delivery. And in 2015, we published our Pump Early and Pump Often Quality Improvement Project. And in that project, we saw that our cesarean birth mothers came to volume more quickly than our mothers who had vaginal birth. Now, I studied with Dr. Peter Hartman in 2007 and have remained in contact with him since 2007. And I had quite lengthy discussions with Peter about why we might see such a thing. And, you know, he said to me, well, Diane, you are having your mothers express early. And so the mothers are being delivered, they're pumping immediately, so it is no surprise to me that they are coming to volume effectively. So we currently have a manuscript under review looking at 468 dyads, all of which had cesarean birth for a baby with a complex congenital anomaly. And we looked at the impact of timing of milk expression on the maternal milk supply post-delivery. Now, I want you to keep in mind that we will even bring the pump into the operating room. And in our study that is currently under review, 90% of our mothers initiated pumping or breastfeeding, if it happened to be a healthier child, in under 6 hours. So for us, an outlier would be those pumping beyond 6 hours, which reinforces Dr. Leslie Parker's work that shows that pumping within the first hour or the pumping within the first 6 hours is critical for milk supply, both at 1 week after delivery and even 3 weeks out. And so with this early attention to pumping, even if there were maternal risk factors for delay in lactogenesis too, they were overruled. They did not impact supply because we were proactively managing their pumping. So obesity is a real risk. About 1 in 2 women are overweight at time of childbirth. We know that women who are overweight, they do not have the same prolactin response when the breast is stimulated and emptied. We know that women who are overweight or obese have a delay in lactogenesis too. and at risk for early breastfeeding cessation or not initiating breastfeeding at all. So this particular research project comes from the University of South Florida. In 2016, I did a visiting professorship with the University of South Florida and Tampa General Hospital to work on several projects to improve human milk and breastfeeding outcomes in vulnerable populations. They have an extremely diverse patient population at the hospital that they serve, with a lot of people of color as well as a lot of low-income families. In this particular study, this was conducted at a midwifery practice, which most people would think, oh, a midwifery practice. These are healthy individuals. But in this sample of 216 women, we found a large portion of women who had high body mass index. And the mothers who had the highest BMIs had the most disrupted lactation. So after controlling for covariates, age, BMI, and gestational weight gain were positively associated with delayed lactogenesis too. So when this study was published, I actually had a reporter contact me, and she was like, well, should we just tell women who are overweight or have high BMIs that they should not even bother to attempt breastfeeding? And I said, absolutely not. What this tells us is that we have to develop a different proactive management style. So even if they are expected to have a presumed healthy diet, we can't just be laissez-faire about milk supply. We have to proactively address the development of milk supply. Now, what about potential families that have breasts that might not work? And this article will be out this year in the Journal of Perinatal Education. And this came from working with one of our nurses who works in the outpatient setting at a pediatric care practice. And she had the experience where she worked with a mother who presented with a child who had a 15% weight loss, and the mother had abnormal breast tissue development, which was never identified prenatally or during the birth hospital stay. So we need to prepare women if they potentially have breasts that may not come to volume. So if we have a mother who's had augmentation or breast reduction surgery, the capacity to complete or have a full milk supply may be impacted. If the ductal structures were severed, milk supply can be impaired. Or if a large amount of tissue is removed, the secretory tissue is also removed. So we cannot treat women who've had breast surgery the same as the general population. We must provide them with prenatal anticipatory guidance and strategies to maximize their milk-making capacity. Our goal would be to help them make as much milk as they can for their child, and also help them realize that every amount or drop of milk they make is worthwhile and important for their child, especially in this time of COVID, because we do know that mothers are able to produce antibodies to the COVID virus. For women who have glandular hypoplasia or insufficient glandular tissue, these women should not be set up to believe that they can provide 100% of milk for their child. Now, this is something that is very easy to identify prior to delivery, because when you observe their breast, they are widely spaced, they are often conical shaped, and the mother will report that she has not had any breast changes during pregnancy. Now, I have published about this already, and, it is very, very challenging for these women because they go into this thinking that they're going to have a baby be able to breastfeed, and then they are totally shocked to learn that their breasts aren't able to make milk. I'm actually working with one of my colleagues at the hospital right now, first-time mother, no idea that she had abnormal breast tissue development, reported no breast growth or change during pregnancy, had her breast assessed, had prenatal care, was seen at the birth hospital. No one identified that glandular hypoplasia till 2 weeks after delivery. At that point, the child had lost significant weight, and the mother now is experiencing post-traumatic stress from that experience. The most amount of milk she is able to produce in a whole 24-hour period is 50 ml. So what are some key points in terms of really preparing families? We really want to be aware that both mothers and infants could have risk factors that may impact the ability for a copious milk supply. We really have to conduct a thorough antenatal risk assessment, and we want to employ a proactive management style to ensure coming to volume. So for the rest of our presentation, we are going to be focusing on that establishment and maintenance of milk supply, which is step 2 of my model. Now, I am going to guess that most of your families worry about milk supply, just like my families that I work with. And when we think about COVID and the fact that many hospitals are separating mothers and children at birth, we have to know that milk supply can be negatively impacted. Again, going back to prenatal anticipatory guidance, we should be educating families that they do make milk from 16 weeks of pregnancy forward. And so having that messaging occur in the prenatal period is so important because many of you know and experience that after delivery, mothers will say things to you like, I have no milk. There's no milk in my breast. Or healthcare providers will say, oh, you don't have any milk yet, so you need to supplement, okay? But we need to change our language. We need to begin talking to families about the fact that they do have milk. It just happens to be a very different type of milk, and that milk is there to lay down the baby's immunobiological system. But it does not matter how early they deliver, because they've been making milk since 16 weeks. It does not matter what type of delivery they have, and it does not even matter if they've had breast surgery or if they've had abnormal breast tissue development, because even those mothers will make milk. The only people who would not make milk are people who don't have breasts at all. So when we think about that role of colostrum and what that is meant to do, right? Colostrum is meant to lay down the baby's immune system, and the baby is only meant to consume small volumes of colostrum because in the beginning, the baby has to learn how to manage how to suck and to swallow and to breathe. And so if the mother was producing copious amounts of milk on delivery day, that poor child would choke and aspirate. So really messaging what is appropriate milk intake. And, when you think about infant formula bottles that you see in birth hospitals, no infant formula bottles look like this picture here, right? And this picture here represents what a baby might consume in an entire 24-hour period as a newborn. And so there is a true mismatch, all right, on what parents see, because they see in hospitals 60 ml bottles of formula, and when I was a brand new nurse, they used to be 120 ml bottles of formula, and then the amount of milk that is being produced by the breasts. So it's no wonder that parents and healthcare providers have this perception that there's not enough milk. But in order to effectively convert from secretory differentiation to secretory activation, the breast has to be effectively stimulated and effectively emptied. And there's a critical window. And if we mess up and don't provide adequate breast stimulation and emptying during that critical window, that's what is going to set up the mother to have suboptimal milk-making capacity for the rest of her experience. And when we think about the birth hospital, again, we have to think about really, is it protecting maternal milk supply? We can think about the influences of labor and delivery, Pitocin, anesthesia, IV fluids, concerns after delivery about infant weight loss, concerns of formula supplementation due to weight loss, potentially a lack of skin-to-skin, and potentially a lack of rooming in because of separation. And we know that even in non-COVID times, mothers were being discharged prior to the onset of lactogenesis too. Here in the U.S., we're seeing that vaginal birth moms are being sent home now within 24 hours, and cesarean moms often within 48 hours. And I've talked to my colleagues across the globe, and they are seeing similar practices. So how is it that a mom is going to effectively establish her breastfeeding and her milk supply with such limited support? So, again, I will always talk about the critical role of the bedside nurse, or that nurse who's in that community center, because if the nurse cannot effectively assess risk factors from both the mother and the infant, we're not going to effectively manage her care to ensure milk volume. So if there's maternal-infant separation, and that could be due to a sick baby or due to COVID, or if the infant isn't feeding well, or if the mother has risk factors, then our number one goal has to be the protection of milk supply. We have data that really shows the first 4 days predicts milk supply long term. And so when we think about mothers and their children, we want to think about that really the most important job that the mother can do is to focus on eating, sleeping, and making milk for her child. So if the mom and baby are discharged together, that means lots of skin-to-skin contact and lots of breastfeeding. And we have to think about mobilizing family and community support. But again, in this time of COVID, what family and community support is going to look like is different. Because with social distancing, families are not together. Because of social distancing, there's no in-person support groups. Because of social distancing, the mother may only be receiving telehealth or telelactation support. But that doesn't mean we couldn't think about other opportunities to engage families via online support groups, or have families engage their family members to do things like volunteer to do the laundry, or bring over cooked meals, or take care of the grocery shopping for a family. For the mother and infant who are separated, milk supply can be compromised. And again, I am talking about both term and preterm because with COVID and maternal-infant separation happening, we have to understand that if babies are not at the breast, we need access to hospital-grade pump technology and that initiation pattern. The pumps that moms purchase or the pumps that moms get from their insurance company are not designed to establish a milk supply. So at Children's Hospital of Philadelphia, we have the Symphony with initiation technology at every single bed spot in our labor and delivery unit. We have the pump at every single bed spot in our neonatal intensive care unit. And for our 565-bed hospital, I think we have well over 300 of these pumps. And so, again, we need to make it easy for the mother to effectively establish supply by having her have the right technology. Now, many of you may argue that pumps are too expensive and parents cannot afford pumps. But when you look at the cost of a pump compared to the cost of formula, even when a parent rents a hospital-grade pump, that is much less expensive than the cost of buying formula. And if you were in my presentation in June, you know that in the U.S., we are seeing increased costs of formula. There is price gouging that occurs, and there's also been formula shortages. So definitely when we think about this from a cost perspective, protecting milk supply is less costly than the cost of infant formula. Now, if a mother is expressing milk, we do need to give her guidance. In this time of COVID, this has been a great concern of people all over the world. What about that mother who's COVID positive? What if she's going to get it into the milk? And when we think about guidance for pumping, whether it be a COVID-positive mother, a mother who is a PUI, or any other mother, the most important thing that we can do is teach the family good pump hygiene. So that involves making sure the pump is wiped down prior to its use. That means hand washing before and after pumping. That means washing of the pump equipment after every use, and that means sanitizing the pump kit every single day. There is no need for the person to wash their breast unless the person was COVID positive and directly was coughing or expectorating onto the chest. And that is detailed in the World Health Organization guidance that I discussed in the webinar in June. In the United States, our Centers for Disease Control and Prevention do provide nice recommendations for how to keep your breast pump clean, and they are available in both English and Spanish. So even if you are from a country outside of the United States, you would be easily able to download these and share these with your families for patient-family education. Again, lots of concern and controversy I've heard around the globe about the worry of handling expressed milk, whether or not expressed milk is going to cause contamination. And from our infection preventionist, this is from Children's Hospital of Philadelphia, there is no need to wipe down the bottles of milk with a cleansing wipe. The main recommendations are proper hand hygiene before and after pumping, clean the outside of the pump prior to using it, and make sure that pump kit is clean. If the mom is symptomatic, she should be wearing a mask for breastfeeding or pumping. I also just have to mention the Flex Shield when we talk about milk expression and breast emptying. If you are not familiar with this, Dr. Danielle Prime, who is in the picture up there with me, this comes from Valentine's Day 2019. We were together in Australia speaking, sadly not with our spouses, so that's why we have our little heart picture there. But Dr. Danielle Prime was a student of Dr. Hartman in 2007 when I studied at the University of Western Australia. And we worked together every day for a whole semester. And so besides being colleagues, we are also now friends. And her research on this new breast shield is really very exciting because she has changed the design of the shield. So it is oval shaped and has a wider opening. And again, this has been published in a peer-reviewed article in May of this year. And not only did the mothers find it more comfortable, but there was an increase in percent available milk drained from the breast by 11%. So when you think about protecting milk supply during this time of COVID, the better that the breast is drained, the more effectively the breast is drained, the higher the milk supply is going to be sustained. And I can tell you from a perspective of my staff that I work with at Children's Hospital of Philadelphia, all of my staff are using the new Flex Shield, and they are obsessed with it both from a comfort and breast emptying standpoint. The research is very crystal clear. There is a critical window to effectively establish milk supply so that if the baby and mother are separated, if the mother has risk, if the infant brings risk, if the baby's not feeding effectively, we need to get the mothers to pump early and often with the right technology. And we have to ensure that they come to volume by day 5. Now, I want to emphasize that if the mother and infant are healthy and the mother and baby are breastfeeding effectively, lots of skin-to-skin contact and direct breastfeeding is always the best thing. Skin-to-skin and direct breastfeeding is the best thing to establish milk supply. But we have to be aware that mothers bring risk, infants bring risk, and the current COVID-19 pandemic is causing risk for milk supply. And we are seeing this play out where I live in our care network sites, our primary care sites, because mothers are presenting with their newborn visit at that first newborn visit, and milk supply has not been established. And then it's really hard to work on now trying to regain that lost time where we didn't have effective breast stimulation and emptying. So I want to share with you just one case example of proactive management. This was a mother who was 44, first-time mother, long history of infertility, an IVF-conceived pregnancy, a body mass index of over 35. And she did end up delivering at a baby-friendly hospital, but she was induced, and she ended up with a cesarean. Now, this mother is someone who I know personally, and she asked me prior to delivery to do a one-on-one consult, just like I would do for a family I care for at CHOP. And I said that I would do that for her as long as she listened to all my instructions. And based on her health history and her risk factors, I recommended her to rent the pump ahead of time, the Symphony Plus with initiation technology, to take to the birth hospital. And the mother said to me, but why do I need to do that? The hospital, they'll have pumps. I said, I know, but they might not give you one. And remember, I said, I told you if we're going to have this conversation, you need to listen to everything I tell you. So she did rent the pump and took it with her. The baby did breastfeed right after birth. The mother started pumping right away. The mom had pretty large breasts and nipples. The baby needed a nipple shield to latch effectively. The mom was breastfeeding and pumping every 2 to 3 hours. At the birth hospital, despite the numerous risk factors she had, the hospital staff actually routinely recommended her to manually express instead of using the pump. On day of life, too, the mother was told to supplement, despite the fact that the baby was breastfeeding well. The mom was pumping and getting colostrum, and the baby was stooling after every single feed. On day of life 3, the mother was again told to supplement, and she refused. The mother did come to full volume. She was lucky enough to have IBCLC visits covered by her insurance, but her and the IBCLC didn't have a really positive relationship. At the end of the day, the mother ultimately decided to just express milk and feed express milk to her baby. She had to go back to work at 12 weeks. And so her reason for that decision is she wanted to spend more time with her child and less time trying to focus on the baby, just getting the baby to feed effectively. And so she ended up renting 2 pumps. And was able, even upon return to work, maintain a completely normal milk supply, and she has reached her goal of providing milk for her baby for over 1 full year of life. So in closing, I just want to speak briefly about this manuscript that was just accepted for publication this week. It will be coming out in the Journal of Maternal Child Nursing. And we interviewed first-time mothers who gave birth during the start of the pandemic in the U.S. And there were 5 key areas that we heard in our interviews, and I'm going to talk briefly about each of them. So, recommendations change every day. And I'm sure where you work, you're still seeing this. I see it every day at my center. In both birth, hospital, and pediatric centers, families receive conflicting and changing recommendations. One mother in particular was told that she couldn't bring her partner to the first newborn visit, and that caused great stress to the mother. The weather was terrible. She had to navigate an umbrella, a car seat, and try to get into the visit. And then when she got to the waiting area, she saw other mothers had partners present. And, you know, she thought about texting her husband, but then said, well, I don't think I should because I felt I needed to follow the rules. So example after example of there were times when there were masks used, not masks used, temperatures checked, temperatures not checked, but recommendations changing every day. Guilt, concern, and stress. Okay, all mothers reported this related to birth and breastfeeding. One mother said her pediatric provider did not establish rapport with her and the visit was cold. Not being able to see faces due to mask was also concerning. She said, I just wanted to get the visit over with as quickly as possible. And another mother said stress repeatedly during the interview. She was worried about the stress impacting her milk supply, the stress impacting her family, the stress impacting her breastfeeding. In-person versus telehealth. Definitely mixed reviews of telehealth. There was a mother who liked it. Another mother said that it was really awkward and she didn't think it was accurate or effective. And all mothers talked about the fact that they were sad about not being able to attend in-person support groups and lactation visits. The mothers very much were missing time with their family and friends. The mothers in particular talked about having family come to the front door. And the one mother said, these visits made me cry. I told friends and family members to stop coming because it just made me feel worse. And another mother described glass door visits as being heartbreaking. And then the one positive or silver linings. The one mother said, you can just be home and in your bra all day. And because the mothers followed social distancing recommendations, there was really nothing else to do but just stay at home and breastfeed all the time. So I think that I have left us a few minutes for questions. I thank you for your time and attention, and Kim will help us manage the questions.
Thank you, Diane, for that great information. It's always a pleasure to listen to your presentations. I always learn so much, and I'm sure our attendees are as well. We do have about 7 minutes for questions, so feel free to send those in via your chat function. We did have one question come in. Someone asked if the Flex Shields were available to the public and where they could be purchased. These can be purchased on the Medela website or through local retailers. And we do have our Breastfeeding National Network information on the website where a mom can plug in her zip code and get information directly from there. Let's see. There is a question that came in, why can't mothers just use hand expression and not a pump?
That's a great question. So the hand expression is useful to get colostrum out. We can absolutely express colostrum. But if you look at the work of Dr. Donna Geddes and effective milk removal, we know that vacuum is how the babies empty the breast. And at peak vacuum is when you see the flow of the milk from the breast into the baby's mouth. And so when someone does hand expression, they are not going to be able to create the same peak vacuum that a healthy term baby would use, or the same peak vacuum that a hospital-grade computer chip technology pump would use. And so it's really about ensuring that we are coming to volume. It's great that we can hand express and get a couple of drops of colostrum, but that's not the same as a baby vigorously breastfeeding for 15 minutes at birth. And so if the baby's not vigorously breastfeeding, all around the clock, right, then we could end up having the mom have suboptimal milk production long term. So most of the time, many of us are very laissez-faire about milk production, right? We're just, let's just wait and see. Let's just wait and see. But the problem is if we just wait and see, we might have already compromised her milk supply, because we have data that show the first hour, the first 6 hours, the first 3 to 5 days impact where milk supply will be 4 weeks out, 6 weeks out. And so it's really about thinking about the need to have milk supply. And, if you don't have milk supply, you're not going to be able to be a breastfeeding mother.
Okay, thank you. The next question that came in is, in your program where moms are so successful postpartum, once she is discharged, do they use an insurance pump, or are you providing them with a Medela Symphony breast pump to use 24/7 during the duration of her infant stay?
This is a really great question, and really it has to be tailored on the maternal-infant dyad. So if it is a mother who has a critically ill child, and we know that that mother is going to be pump dependent maybe for, 1 month or 2 months or 3 months because of her child's diagnosis, then we do have the mothers use the hospital-grade technology for that whole time. But if it's a situation where we know that that baby is fairly quickly going to be able to transition to direct breastfeeding, and the mom may only need that computer chip technology for a week or two, she then may be able to transition to a personal use pump. Because remember, personal use pumps are designed for families who have already established breastfeeding. They have been breastfeeding full time and now they are going back to work or school. They're not designed for people who are initiating and trying to come to volume. It's all about coming to volume.
Okay. Then there's a second part of that question. The second part is, aren't the high volumes found in research a result of the mom using Symphony 24/7 versus a personal pump? Then upon discharge of a baby, can she opt to personally rent a pump?
Absolutely. I mean, for mothers who have sick babies, that computer chip technology is definitely the preferred technology to ensure milk supply long term. I can tell you, being old and having done this a long time, that once a mother comes to full volume, and many of our mothers are making a liter of milk a day and can make a liter of milk a day for a year, it's easier to sustain that long term if you get off to the right start. And so some women can transition from a hospital grade to a personal use pump and still sustain that supply. But I'll just tell you, for example, in our employee program at our hospital, our employees have access to computer chip technology as well. And if you ask employees, would you rather, use the pump that you've got from your insurance or the hospital grade technology, they all are going to opt for the hospital grade technology. And this is a little off topic, but in some research that we did with one of my MPH students, she did a project where she looked at lactation preferences of healthcare workers in an academic medical center. And the number one request of healthcare workers was having access to hospital grade pump technology when they went back to work.
Great. Thank you for answering that question. It looks like we're at the top of the hour already. It went fast. Just a couple of things before we end the call today. Thank you again, everyone, for joining us today. If you're interested in getting more information about the Flex Shield or initiation technology, please feel free to email education@medela.com and we'll get you that information. Also, we do have a few more webinars coming up. The information and registration is available on our website for the July 15th, the July 21st, and the August 19th webinars. We'll also be having a special webinar on July 16th presented by Rebecca Powell, and this one covers COVID antibodies, and that's next Thursday. So to find out more information, please visit medelaeducation.com. Your certificates for the U.S. attendees will be available tomorrow, and the handouts will be emailed out tomorrow as well. Have a great afternoon. Enjoy your day, and thank you again for attending.